مش مبين. Okay. To assess the metabolic profile of an area or a lesion of the brain in vivo. It helps, number one, identify the metabolite, and number two, to quantify the concentration of this metabolite. So the spectrum is an amount of metabolite peak concentration against the chemical shift or frequency in part per million. This is at 7 Tesla human adult brain. You can see and appreciate single voxel spectroscopy with multiple metabolites. And this is the region of interest. It's about 8 cc. Of course, as you increase the voxel size, you get more information. So regarding the interpretation of N-acetyl aspartate, it lies at 2.02 part per million. The concentration is 7.8 millimole. Low NAA is seen in neuronal loss, axonal loss, impaired neuronal function or integrity, decreased neuronal density, and increased brain water content. So that's why in neonate or pediatric age group, there is more water as compared to adult. Increased NAA is seen in impaired degradation of N-acetyl aspartate due to deficiency of aspartate acyclase enzyme, ASPA. And this is pathognomonic for diagnosis of Canavan's disease. Interpretation of creatine. We need to know creatine is synthesized in the liver from arginine. It's low in hepatic encephalopathy. So it's either decrease in synthesis will cause low creatine or defective transport from the liver to the brain. And you can differentiate this by giving creatine. If the spectrum improves, so this is a defect in the synthesis of creatine rather than the transport. And of course, in the spectrum, you'll see low creatine signal in creatine deficiency states. Creatine is rather stable. That's why we usually use it in ratios. You hear Na over creatine, choline over creatine. It's relatively stable. It doesn't change much. It reflects the energy or the intracellular metabolism. So we use it as a reference metabolite. Usually we see creatine higher in concentration in gray matter more than white matter due to high energy metabolism in the gray matter as compared to the white matter. Interpretation of choline. This is very important to differentiate between hypomyelination versus hypermyelination. If you see low choline, it suggests more hypomyelination, while increased choline and myoinositol will take you or think about demyelination or dysmyelination. Gliosis, increased number of glial cells, you will see increased choline level. Elevated brain membrane turnover, you will see high concentration of choline. And of course, choline helps us in monitoring of treatment response, recurrence versus radiation necrosis. It's very important to look at the choline and choline over creatine ratio. Lactate, it's seen at 1.33 parts per million, and usually it is inverted below the baseline in long TE. You see it in anaerobic non-oxidative glycolysis. Any detectable lactate is abnormal, especially in the adults, of course. You see lactate in hypoxia, ischemia, necrotic cystic tumors, mitochondrial diseases, Tissues with poor washout, like cysts and incisors. Interpretation of myoinositol. It is seen at 3.56 part per million, and the concentration is about 3.8 millimole. It is an organic osmolyte. It's a sugar. You see it low in cases of hyponatremia. It's high in neonates, so if you see it, don't think it's abnormal in neonates. In myelin degradation, in cases of gliosis, gliomatosis cerebri, and in diabetes and hyperosmolar states. Interpretation of GLX, or glutamate and glutamine. It lies in the 2.2 part per million. Glutamate is 10 millimolar in concentration, glutamine 5 millimolar. Cases of decreased GLX, you see it in AIDS, dementia, and in Alzheimer's disease, and increased GLX in hepatic encephalopathy due to increased ammonia levels and urea cycle metabolism abnormalities. And you see it also in hypoxic ischemia. Interpretation of myoinositol. Did I go back? Yes. Okay, what's the anatomical variation of brain spectrum in young adult brain? This is very important. At the level of the lateral ventricles, the choline and Na are usually higher in the white matter, while creatine is higher in the gray matter because the gray matter requires more energy. At the level of the third ventricle, you see, for instance, Na and choline is high in the pons. Choline is higher at the insular cortex, and it is lower at the occipital and the visual cortex. In the cerebellum, you see higher creatine and choline relative to the rest of brain regions. Anatomical posterior, anteroposterior differences. For instance, in the hippocampus, you see lower Na and higher choline in the anterior region of the hippocampus. So these are anatomical variation we need to put in mind before we diagnose or reach a conclusion. This is a T1 image at several levels. This is above the ventricle. So if you see here, choline and Na is higher at the white matter. In the cerebellum, choline and creatine is higher. This is a lower cut. And here, the pons higher in Na. Technical aspects of neonates or infant or child. First of all, these kids, you need to sedate them. And they say usually the propanediol, which is a solvent in anticonvulsants or in the sedative, it can show you a peak at 1.1 and should not be misdiagnosed as lactate peak at 1.3. Not be misdiagnosed as hypoxic brain. In infants also, there is no adequate signal-to-noise ratio because of the small heads. It has a very high water content, so there will be poor resolution of metabolites and little signal. And of course, you need a dedicated head coil to increase the signal-to-noise ratio. And of course, because it's a small brain, you will use a smaller voxel size. It's not like the adult brain. The bigger voxel is better. Neonatal brain, the spectral changes depends on changes in metabolic composition of the brain, myelination of the brain, the neuronal connections, deposition of iron, and the water content. So over the first 3 years of life, there is gradual normalization towards the adult spectrum. At birth, if you see increased myoinositol and it dominates the spectrum, this is okay. It's not abnormal. Choline is higher in concentration than Na. By 18 months, it starts to normalize. 3 years and older, it should be normalized like an adult brain. where NAA is the dominant 5 months, 4 years, and adult. If you see here, the myoinositol and choline is higher level than the NAA. As this child grows older, the NAA dominates the spectrum. How to evaluate a lesion in the pediatric group? If there is a unilateral lesion, you compare it exactly in the mirror image location of the opposite side. Okay, what if it's a global lesion? So you really need to have a reference. You need to compare it with a normal age and gender matched control. And the recommendations to use a ratio rather than the absolute concentration to compare. In hypoxic ischemia, proton MR spectroscopy is very sensitive. That's the beauty of MR spectroscopy. It can show you changes before your radiological eye can see, especially in the first 24 hours of the insult. You have elevated lactate and GLX. So these are early markers of acute injury. So again, in the acute phase, the first 72 hours, so it's really non-specific. And it's not really about the etiology, it's about the metabolism at the cellular level. This is a case of a watershed injury in a 2-day-old neonate. So here is the propanediol at 1.1, and this is the lactate at 1.3. And these arrows are pointing at the watershed injury. In brain tumors, there were attempts to differentiate different kinds of brain tumors, but in general, these attempts didn't really help. Most of them, it's elevated choline and reduced NAA. In cases of hamartomatous lesion, elevated myoinositol in the dysplastic lesion. In supracellular tumors, like craniopharyngioma, in pituitary adenomas, it's either normal spectrum or you can find an increased choline peak. MRSI is very important in distinguishing recurrent tumor from radiation necrosis. If you see a choline over creatine ratio above 2, so this is more of a recurrent tumor, because you know that radiation necrosis may mimic the appearance of, you don't know if the patient is improving or not. And of course, in necrosis, there is global reduction in all brain metabolites. In temporal lobe epilepsy, low NAA and increased choline. White matter diseases. Of white matter disorders, I'm not going to go.